Welcome back to the Deep Dive, where we take complex topics and unpack them into clear, actionable insights.
Great to be here.
Today, we're plunging into one of the most crucial yet technically challenging procedures for us as interventional radiologists, adrenal vein sampling, or AVS. It's often called the gold standard for a reason, especially when it comes to managing a condition called primary aldosteronism. We've got a stack of sources here that truly get into the nitty-gritty.
That's right. And our mission today is really to distill the most vital insights on AVS, starting with the foundational planning steps, moving through the intricate technical maneuvers.
The hands-on stuff.
Exactly. And navigating the anatomical quirks, which can be significant.
Yeah.
And then critically, how to interpret those vital results.
Because primary aldosteronism, PA, it's actually pretty common, isn't it, for a secondary cause of hypertension?
It really is the most frequent secondary cause, actually, affecting maybe 5–10% of screened hypertensive patients. And here's a critical insight, something that really underscores why we do this. While imaging, like CT and MRI, are essential first steps.
Sure, you need the scan.
Absolutely. But they can be surprisingly insufficient for definitive subtyping. Studies show up to a 40% discordance between what imaging suggests and what AVS actually reveals.
40%, that's huge.
It is. And relying solely on imaging can tragically lead to an inappropriate adrenalectomy or even, operating on the wrong side entirely.
That's a sobering thought.
So AVS is far more than just another diagnostic test. It's a critical determinant for effective, often curative treatment.
Okay, that 40% figure really hits home. So let's unpack this. Before we even think about picking up a catheter, what's the blueprint for success in AVS? Setting the stage correctly seems paramount.
It absolutely is. Meticulous pre-procedural planning is, it's key.
So first up, indications. Who gets AVS?
Right. Primarily, it's for patients with biochemically confirmed PA who are actually candidates for surgery.
Makes sense.
We use it to distinguish unilateral one-sided versus bilateral two-sided causes, especially when imaging is unreliable or maybe conflicts with the blood test results.
Okay.
It's also getting traction for investigating laterality in subclinical Cushing's syndrome, SES, and for characterizing hormone production in other adrenal situations, even hyperandrogenemia sometimes.
Interesting. Even outside classic PA.
Yeah, and interestingly, AVS can still be useful for patients maybe with normal aldosterone levels, but a high aldosterone to renin ratio, the AR. Many of them can still lateralize and potentially benefit from surgery.
So it casts a wider net than you might initially think. Conversely, what are the absolute no-goes, the contraindications?
Good question. We generally wouldn't do AVS if a patient just prefers lifelong medical treatment, or they're unwilling to have surgery, or maybe they're just a poor surgical candidate overall.
Okay, patient choice and fitness.
Exactly. Also, specific genetic forms like familial PA types IN3 adrenalectomy doesn't work for their bilateral secretion, so AVS isn't needed.
Right.
And if adrenal cortical carcinoma is suspected or confirmed on imaging, well then surgery is the next step without AVS.
Straight to surgery in that case.
Yes. There's also a bit of a debated exception for younger patients, say under 40, with recent onset PA, a clear unilateral adenoma on CT, and a normal other side, if they're willing to go straight to surgery.
But that's controversial.
It is, yeah.
Yeah.
Because there have been documented cases where the biochemical cure fails. So caution is advised there.
That makes a lot of sense. Okay, beyond patient status, medications must be a huge factor, right? Given the hormones involved.
Oh, absolutely vital. Careful adjustment of antihypertensives is critical. Things like MRAs, spironolactone, eplerenone, and amiloride, they need to be stopped. At least 2 weeks, ideally maybe up to 8 weeks.
8 weeks? Wow, that's a long time off meds.
It can be. ACE inhibitors and ARBs also need to be stopped. If stopping MRAs is just not feasible, measuring plasma renin can be an alternative assessment.
And what do you use for blood pressure control in the meantime?
Good question. We tend to prefer peripheral alpha-1 blockers like doxazosin, prazosin, or long-acting calcium channel blockers like verapamil or diltiazem. They seem to affect renin the least.
Okay. And what about simple things like diet or potassium?
Very important. Patients should maintain an unrestricted sodium diet.
Why is that?
Because a low-sodium diet can paradoxically cause both adrenals to secrete aldosterone. It completely messes up the results.
Oh, okay. Good tip.
And serum potassium must be corrected, needs to be above 3.5 millimole if they're hypokalemic. Low potassium inhibits aldosterone production, plus it increases arrhythmia risk during the procedure itself.
Right, safety first. Okay, preparation is key. Now, about imaging beforehand, that pre-procedural CT, how critical is that for actually guiding the procedure?
It's not just helpful, it's, I'd say, fundamental. Everyone needs pre-procedural cross-sectional imaging. CT is generally preferred over MRI.
Why CT?
It's just better for seeing small lesions, fat-poor adenomas, and crucially for planning. It visualizes the right adrenal vein, the RAV, in a really high percentage of cases, over 90%.
That's impressive.
It helps rule out carcinoma, sure, but mainly it gives you that detailed map of the adrenal vein anatomy and any variations in the nearby big vessels, like the left renal vein or the IVC.
So you know what you're getting into.
Exactly. It lets you anticipate the RAV's likely takeoff point, the IVC shape. It saves a ton of time in fluoro and avoids a lot of difficulty during cannulation. It really changes the game from potentially fumbling around to a much more predictable approach.
Like having GPS for the veins. And finally, patient counseling and timing. Managing expectations must be important.
Hugely important. You need a frank discussion about the technical challenges and the possibility, which is real, that the study might be non-diagnostic and need repeating.
Set expectations realistically.
Yes, a pre-procedure clinic visit with the interventionalist doing the case is ideal. Review meds, check potassium again, talk through risks. As for timing, early morning is best. It helps level out the diurnal hormone fluctuations. You want natural cortisol levels to be at their highest for assessing selectivity properly. And patients should be lying supine for at least an hour before starting.
Okay, meticulous prep done. Now the really interesting part, the hands-on procedure. Once the stage is set, what are the key technical maneuvers, the tips and tricks for actually doing a successful AVS? And what tools are we using?
All right, this is where the skill comes in. Standard access is usually the right common femoral vein, a 5 French or 6 French sheath, often under ultrasound guidance for safety.
Why femoral?
It generally gives the best angle, especially for the right side. Internal jugular access can make the left side a bit trickier, actually. And a 5 French sheath is neat because it lets you collect peripheral blood samples continuously if you need to.
Got it. And once you have access, the catheters and wires, these veins are tiny. Selection must be crucial.
Absolutely critical. For the right adrenal vein, the gray OV, we often use specific pre-shaped catheters, like a C1 or a SIM1, though others, like a Cobra 2 or Shepherd Hook 2, work too.
Any special features on these catheters?
Some, like the Van catheter, have side holes near the tip. This helps with sampling if the end hole is up against the vein wall. In fact, it's pretty common practice to manually create 1 or 2 tiny side holes near the tip ourselves.
Really? Why?
Improves flow, reduces the chance of the catheter tip thrombosing off.
Clever. And for the left side?
Left is usually easier.
Yeah.
C1, C2, maybe a SIM2 or SIM3. The SIM2 Glidex is often quite nice, moves well. Since the LAV is typically larger, just a simple end-hole catheter is usually fine. Standard 0.035-inch guide wires are common. But sometimes for extra fine control, you might use a 0.018-inch wire coaxially through the catheter.
And microcatheters, are they used much?
Increasingly so, yes. Things like the ProGrade microcatheter, especially vital if you're doing super selective sampling, which we can talk about.
Okay, now I've heard a lot of debate about using cosintropin or ACTH during AVS. What's the deal with that? Pro, con?
Ah, yes, the ACTH debate. It's definitely a topic. Proponents argue it boosts cortisol levels, which helps with the selectivity index calculation. It might stabilize hormone fluctuations during the procedure.
Makes the numbers more reliable.
Potentially. And some argue it can increase procedural success rates, maybe even making cannulation easier by increasing adrenal blood flow. A meta-analysis did show it reduced incorrect lateralization and failed cannulations.
Sounds pretty good. What's the downside then?
The main concern is that cosintropin can stimulate aldosterone production from the normal adrenal gland too, which could potentially mask a unilateral source, making it look like a bilateral case when it isn't. There's data showing a noticeable increase, maybe 20–25%, in bilateral diagnoses when stimulation is used.
So it helps technically, but might muddy the diagnostic waters. Tricky balance.
It is. If used, it's usually continuous infusion starting maybe 30 minutes to 2 hours before sampling, or sometimes a bolus followed by an infusion. Practice varies.
Okay, so you've cannulated the vein, maybe with ACTH, maybe not. What's the actual sampling protocol? How do you get that precious blood without messing things up?
Gently is the key word. Once you think you're in, you do a venogram. Very gentle, slow, low-volume contrast injection. We're talking tiny amounts, like 0.1 to 0.3 millimilla, maybe up to 3 millimilla max.
Just enough to confirm position.
Exactly. Confirm position and avoid rupture. Forceful injection is a huge no-no. These veins are fragile. Another key point, Avoid cannulating too deeply into tiny side branches or radicals with your main catheter.
Why's that?
You could end up sampling beyond a crucial tributary, or worse, cause a rupture or a venous infarct. That can lead to false negatives. We usually do another quick confirmatory venogram after sampling, too.
Makes sense. And getting the blood itself.
Again, gentle aspiration, intermittent pulls, or even just letting it drip out by gravity sometimes. You want to avoid high negative pressure, which could just collapse the vein. And always waste the first couple of cc's of aspirate. Get rid of any contrast contamination. Then aim for about 10 millimoles from each adrenal vein. And don't forget the reference sample from the IVC below the renals or a peripheral vein.
Peripheral or IVC, okay. Heparin use.
Some operators do give intravenous heparin, yeah, to try and decrease the risk of catheter-induced thrombosis in the adrenal vein. Practice varies on that, too.
Lots of nuances. What about rapid cortisol assay? I hear that's a big help.
Oh, it's a massive help. A real game changer, many would say. Rapid cortisol assay, RCA, gives you feedback almost immediately, often within a couple of minutes, whether your sample is selective enough.
So you know right away if you need to reposition and resample.
Exactly. It allows for rapid resampling if needed.
Yeah.
This significantly boosts technical success rates, like from maybe only a third succeeding on the first try to over 90% in some series. And importantly, it reduces radiation exposure because you're not spending ages wondering if you're in the right spot or having to bring the patient back for a repeat procedure. Plus, it definitely shortens the learning curve for radiologists new to AVS.
Huge benefits all around. Now, you mentioned super selective AVS earlier. How is that different and when would you use it?
Right, assess AVS. It's a more refined technique where you use a microcatheter to go deeper into specific segments within the adrenal gland or its venous tributaries.
I go deeper.
To investigate specific areas. For example, trying to find a small aldosterone-producing nodule while identifying segments that are not overproducing. This might open up possibilities for adrenal-sparing surgery, maybe even in bilateral cases.
Very sophisticated.
It is. It's particularly useful in novel PA types, known bilateral PAs, or those really tricky cases where conventional AVS just doesn't give a clear surgical target, like that double-down scenario we mentioned.
Remind me about that.
That's when both adrenal samples show an aldosterone to cortisol ratio that's paradoxically lower than the peripheral sample, even when you know you got selective samples based on the cortisol. It's also called ABAS, apparent bilateral aldosterone suppression.
And that means what?
Well, that's the problem. It's not diagnostic either way. It doesn't point to unilateral or bilateral disease clearly. Could be you sampled during a lull in secretion, or maybe you accidentally sampled a non-secreting part of the gland, or there's weird venous drainage, or even ectopic production somewhere else.
So what do you do then?
Repeat AVS is often recommended, and specifically using super selective sampling this time to try and hunt down that missed source or understand the drainage better.
Fascinating. It really is like detective work. Which brings us neatly to the anatomy itself. It's not straightforward, is it? Especially these tiny variable veins.
Not at all. A precise understanding of the anatomy is absolutely fundamental. These veins are small, highly variable. It all goes back to how they develop embryologically. Both glands have a central vein, but beyond that, expect variations.
And the right adrenal vein is the usual suspect for causing trouble, right? Because it drains straight into the IVC.
Spot on. The RAV is notoriously the most challenging. Failure to cannulate it is the #1 reason for an unsuccessful AVS procedure.
Why is it so tough?
It's tiny, maybe 3 to 5 millimeters wide on average, sometimes only 2. And it's short, often just a centimeter long, maybe even less. And it usually drains directly into the posterior wall of the IVC, typically around the T11, T12 level.
And it can be duplicated.
It can. Duplicated, even tripled sometimes. And if it is, and you sampled the wrong branch, your results can be totally misleading. Another pitfall is mistaking it for small accessory hepatic veins. They can look similar on a venogram initially.
How do you tell them apart?
If you inject a bit more contrast, maybe wait a little, the accessory hepatic veins will often show a characteristic blush in the liver parenchyma itself. The adrenal branches won't do that. They stay distinct.
Okay, good tip. Are there any classic appearances or landmarks for the RAV on venography?
Yes, definitely. You look for certain patterns, maybe a gland-like pattern with a central stem and branches fanning out, or a delta shape, sometimes just a triangular blush.
Yeah.
Seeing thin, spidery branches helps. And if you see tiny emissary veins draining off the adrenal capsule, especially the inferior one, that's a really high confidence sign you're in the right spot. They can be good landmarks.
What about the IVC itself? Can that cause problems?
It can, yeah. If the patient is a bit dehydrated, the IVC might collapse into more of an oval shape rather than round. This can make fine-tuning the catheter angle to engage the RAV orifice really difficult because the tip wants to lie along the long axis of that oval. It's a common frustration.
I can imagine. Now the left side, generally easier.
Generally, yes. The left adrenal vein, LAV, usually has more consistent anatomy. It typically joins the inferior phrenic vein first.
Forming a common trunk.
Exactly.
Right.
And that common trunk then drains into the top aspect of the left renal vein. It's longer too, maybe 1 to 4 centimeters to that junction, and a bit wider, 4 to 5 millimeter average diameter. Most people sample from that common trunk.
But variations still exist.
Oh, yes. Sometimes that common trunk is absent or the central vein is very short, happens in maybe 3% of people. Or it might join up with other veins in a way that dilutes the adrenal blood. Rarely, the LAV and sphenic drain separately into the renal vein or even directly into the IVC.
So even the easier side isn't always easy.
Nothing is guaranteed in AVS anatomy, which, again, just hammers home why that pre-procedural CT map is so incredibly valuable.
Absolutely. Okay, we've navigated the treacherous veins, we've collected the samples. Now, the moment of truth, interpreting the results. How do we know if we even got good samples? And what do the numbers actually tell us? This is really where it all comes together, right?
It really is. This is where the biochemistry meets the radiology and guides that crucial decision, unilateral versus bilateral disease. First off, technical success rates themselves. They vary a lot in the literature.
How much variation?
Anywhere from, say, 40% up to nearly 100%. It really depends on the operator's experience, the center's volume, and how strictly they define success.
Is there a known learning curve?
There is. It's estimated at around 20 to 30 cases to get comfortable, and probably doing around 15 procedures a year is needed to maintain proficiency. Specialized, high-volume centers just tend to have better success rates.
Makes sense. And things like intraprocedural CT or RCA help boost those rates?
Definitely. Cone beam CT during the procedure can help, especially in tough cases or for less experienced operators. And as we said, RCA significantly improves technical success.
Okay, so assuming we think we got the samples, how do we confirm they are truly adrenal venous blood and not diluted or from somewhere else? The quality check.
That's the selectivity index, or SI. This is your confirmation of adequate cannulation. It's based on the cortisol gradient, comparing the cortisol level in your adrenal vein sample to the level in your peripheral or IVC sample.
How's it calculated?
Simple ratio. Cortisol in the adrenal vein divided by cortisol in the peripheral IVC sample. The cutoff values vary a bit, especially depending on ACTH use.
What are the typical cutoffs?
Commonly, without ACTH stimulation, you want an SI of 2.0 or greater. If you did use ACTH stimulation, the cutoff is higher, usually 3.0 or greater. Some centers even use 5.0 or greater.
And if it's below that?
Below the cutoff suggests your sample might not be purely adrenal, or it's significantly diluted. You might need to question that sample's validity.
Okay, SI confirms the sample quality. Now, the big one. Determining lateralization. Is the problem one-sided or two-sided?
That's the job of the lateralization index, or LI. This compares the aldosterone secretion between the two sides, but it corrects for any dilution differences by normalizing aldosterone to cortisol on each side first.
How is that calculated?
You take the aldosterone to cortisol ratio from the suspected dominant side and divide it by the aldosterone to cortisol ratio from the non-dominant side.
And the magic number there?
Again, depends on ACTH. Without stimulation, a common LI cutoff is greater than 2.0. With stimulation, it's typically greater than 4.0.
And if the LI is above that cutoff?
That suggests lateralization. The aldosterone production is predominantly coming from one side. This points towards a unilateral source, like an aldosterone-producing adenoma, APA, or maybe unilateral primary hyperplasia, PHA. Importantly, higher LI values tend to correlate with better outcomes after adrenalectomy.
Good to know. What if you just couldn't get a good sample from one side? Is there any other way to infer lateralization?
Yes, there's an adjunctive measure called the contralateral suppression index, or CSI. This can be helpful if, say, you got a good left sample but couldn't confirm selectivity on the right.
How does CSI work?
You compare the aldosterone to cortisol ratio in the non-dominant adrenal vein sample when you did get, to the aldosterone to cortisol ratio in the peripheral sample, if that CSI is less than 1.
Meaning the non-dominant side's ratio is lower than peripheral?
Exactly. It indicates suppression of aldosterone production on that non-dominant side, which implies the other side must be the one overproducing. It supports lateralization.
Clever backup. Given all this, what are some common pitfalls or really challenging scenarios when interpreting these results?
Several things can trip you up. We mentioned sampling too deep in a branch, missing the main vein that can cause a false negative.
Right.
Also, some larger APAs can actually co-secrete cortisol.
Cortisol and aldosterone.
Yes. And that excess cortisol from the tumor side can mess up the calculations. It might artificially lower the LI, making it look non-lateralizing, or even make the contralateral side look non-selective because its cortisol gradient seems lower in comparison.
What do you do then?
You really need to consider the whole clinical picture history. Maybe do a dexamethasone suppression test to assess that cortisol co-secretion. And then there's that really perplexing double down or ABS result we discussed.
Where both sides look suppressed compared to peripheral.
Right, not diagnostic either way. Potential causes are numerous sampling during a quiet phase, heading a non-functioning tributary weird drainage ectopic production. In those cases, repeat AVS, possibly with super selective sampling, is often the next step.
And what if you just flat out failed to cannulate the right side, despite best efforts?
There's actually a technique where you can try to calculate an estimated right adrenal vein aldosterone level using the data you do have from the left adrenal vein and the IVC. Studies have shown this calculated method can have pretty high sensitivity and specificity, so it's a potential salvage option.
Interesting. Okay. Like any invasive procedure, AVS has risks. What should we be aware of regarding complications and also the inherent limitations of the technique?
Absolutely. While AVS is generally considered safe in experienced hands today, it's definitely not risk-free. Historically, if you look back at older papers, complication rates were reported higher, maybe around 10%. Things like vein rupture, adrenal infarction, hypertensive crisis.
So things have improved.
Massively. More recent large studies show major complication rates are actually very low, down around 0.6%, maybe even less.
What changed?
Mostly a better understanding of the procedure, refined techniques, microcatheters perhaps, and crucially that emphasis on gentle, low-volume venography we talked about, not blasting contrast.
That's a huge improvement. But complications still happen. What's the main one to watch for?
The most significant, though still rare, is adrenal hemorrhage. Occurs in less than 1% of cases overall.
Is it more common on one side?
Yes, it's at least 3 times more likely on the right side.
Why, they're right.
Probably a combination of the RA being smaller and more fragile, and maybe the left side has a bit of a pressure release valve effect because the LAV joins the phrenic vein into that common trunk. Older age is also a risk factor.
How does it present?
Patients might get chest, flank, or abdominal pain. Imaging, like a post-procedure CT, might show contrast pooling or staining in the gland enlargement, maybe some hyperdensity from the blood.
How serious is it? How's it managed?
Usually it's managed conservatively. Overnight admission for observation, pain control, blood pressure management. Arterial embolization or blood transfusions are rarely needed. It typically resolves over 2-3 months.
Does the hemorrhage cure the PA if it's on the side of the adenoma?
Unfortunately, no. Aldosterone production usually continues despite the hemorrhage, and surgery after hemorrhage can actually be more difficult because of scarring and adhesions.
Any long-term consequences of hemorrhage?
One important one. If the hemorrhage occurs in the contralateral non-diseased gland, and the patient then has their APA surgically removed, they could potentially develop adrenal insufficiency. So follow-up and possibly hormone replacement might be needed in that specific scenario.
Good point. What causes hemorrhage usually?
Excessive pressure during contrast injection is thought to be a primary cause, and while microcatheters help with selectivity, there's some thought they might slightly increase the risk of right-sided hemorrhage, perhaps due to deeper cannulation or vessel wall irritation.
Beyond hemorrhage, what other potential complications are there?
You can get adrenal vein thrombosis or perforation, especially if a catheter is left wedged in place for too long. Hypertensive crisis, while rare, can happen. Adrenal insufficiency, as we mentioned. And then the usual access site issues, groin hematoma, very rarely venous injury. Sometimes contrast can leak out, causing discomfort, but usually no major hematoma.
Okay, so even with improved safety, AVS isn't perfect. What are some of the key limitations we should acknowledge?
Well, a big one is simply access to the procedure. It's technically demanding, requires specific expertise and equipment, so it's mainly offered at specialized referral centers. This leads to significant underutilization, unfortunately.
So patients who might benefit don't always get it.
Exactly. Another limitation is that a notable percentage of procedures can still be non-diagnostic, requiring repeat attempts. And as we've touched on, there's still quite a bit of variability in protocols ACTH use, interpretation criteria, the indices used across different institutions.
The lack of standardization.
Yes, and that can lead to variations in how patients are classified, treated, and what their outcomes are. It makes comparing data sometimes difficult. And finally, that issue of cortisol co-secretion from some adenomas can definitely complicate interpretation and potentially lead to false bilateral results.
Right. So, wrapping this all up, this deep dive into adrenal vein sampling really highlights its absolutely pivotal role, doesn't it? It seems indispensable for really changing the outlook for patients with primary aldosteronism.
I absolutely agree. AVS truly remains the gold standard, the essential tool for precisely subtyping PA. And that distinction is critical because it directs patients towards either a potentially curative surgery or necessary lifelong medical management.
And its necessity is really driven by those imaging limitations we discussed.
Precisely. Conventional imaging just isn't reliable enough on its own to localize the aldosterone excess accurately in many cases. Successful AVS hinges on that meticulous pre-procedural planning, the med management, the detailed CT mapping.
Knowing the anatomy beforehand.
Yes, identifying those vascular variations, picking the right catheters, it all boosts technical success and minimizes patient risk and exposure. Then you add in tools like rapid cortisol assays.
For that immediate feedback.
Exactly. Improves efficiency, cuts down radiation. And center-selective AVS gives us a powerful option for those really complex or diagnostically challenging cases.
And while complications exist,
They do, but things like adrenal hemorrhage are thankfully rare now with modern techniques. But the procedure is technically demanding. It really requires highly skilled, experienced interventional radiologists, ideally working in specialized high-volume centers.
it sounds like a team sport too.
Absolutely. Effective management of PA relies heavily on a collaborative, multidisciplinary approach. We need to work closely with our endocrinology colleagues, with lab medicine specialists, to make sure the diagnostic power of AVS is fully translated into the most effective, targeted therapies for each patient.
It's such a fascinating intersection of anatomy, physiology, and technical skill. Given that remarkable anatomical variability and the fine line between diagnostic success and, say, a complication like hemorrhage, how do you see the future? Could advancements in imaging, maybe real-time biochemical analysis during the procedure, further refine AVS? Perhaps make it even more accessible without losing that critical diagnostic accuracy? It's certainly something to think about.